This training is in partnership between Nevada Primary Care Association, UNLV Lindsay Institute, and Southern Nevada Addictive Disorders Training Project. I want to take a moment to thank Dr. Hunt, Stephanie Boreen, and our presenter, Roberta Miranda, for their help in coordinating this session with us. Before we get started, I'd like to go over a few items with you so that you know how to participate in today's event. During the presentation, please make sure that your phone or computer is on mute so that we don't have any feedback or background noise. And also, please be sure to make sure your phone is not on hold so we don't hear your hold music. We will have the opportunity to submit questions to today's presenter by typing your questions into the chat section of the control panel. You may send your question in at any time during the presentation. Roberta will be answering some of those as she goes, and others will be collected and addressed during our Q&A session at the end of today's presentation. Today's session will be recorded and will be emailed to all participants within 48 hours. We've also added some resource materials for you that you can find underneath your materials box in the little attendee bar. And if you can't get those for some reason, you can always email us and we can send those out to you. This webinar has been approved for one continuing education unit by the Nevada State Board of Nursing through UNLV. If you're applying for the nursing CEU, you'll be emailed a separate evaluation to receive that credit. The other CEUs on this list are pending. If you're licensed by any other board that's not on this list, you will be sent a certificate for your records that you can turn into your licensing board. Now we'll start. Roberta Miranda is a full-time lecturer at Nevada State College, duly licensed mental health and substance abuse counselor and clinical supervisor and trainer of SBIRT. I would now like to introduce Roberta Miranda.
Thank you so much, Brandy. I think we're going to switch over to my screen, correct?
Yes.
All right. So thank you so much, Brandy, for the introduction. Hello, everybody. Thank you so much for joining us for our 1-hour workshop on SBIRT, which stands for Screening, Brief Intervention, and Referral to Treatment. According to the poll, it looks like some of you already have some information on SBIRT, and some of you, this might be some new information. So I'm eager to get started. So welcome. Just to jump into, because we have quite a bit to cover in the next 45 minutes or so, because I do want to leave a little bit of time for questions. The goal for this afternoon is to learn the fundamentals of the SBIRT model, to really spend some quality time talking about communication techniques that might help promote patient engagement. And hopefully you'll find some of these techniques even helpful just in your day-to-day interactions with your patients. We're going to take a glance at some screening tools that can be administered to your clients, and then maybe just see what that might look like in your workplace. As Brandy mentioned, if you do have any questions as we go through the material, feel free to just write those in the chat box, and I will do my best to get to them. It may not be immediate because we may be covering, if you do have a question, we may attend to it a little bit later in the workshop. However, I will do my best to see if I can answer that for you. All right. Oftentimes, as I had mentioned, as Brandy mentioned before, I've had the opportunity to present on SBIRT in the past. The Lindsay Institute, as part of UNLV, they received a grant from SAMHSA that really, I believe it's a 3-year grant that's been utilized to educate the community as well as students at CSN, Nevada State College, and UNLV. And I've had the opportunity to teach both in the classroom and in the community. However, many of those workshops take 3 to 6 hours to cover the material. So what I've done here is really I've done my best to try to condense some of the highlights and provide a nice overview of SBIRT. So if any of you are interested in learning a bit more, please don't hesitate to notify me or Brandy or one of the contacts at the Lindsay Institute to learn about some longer workshops that are available. And then sometimes in those workshops, there's an opportunity to practice some of the screening tools and the communication skills a little bit more in depth. However, we're going to do our best to cover some great highlights so that you walk away knowing what SBIRT is. So let's dive into it. What does SBIRT stand for? As I mentioned, it's an acronym. There's a screening component, a brief intervention, and referral to treatment. And I need to minimize this so I can see my own screen here. And it's an evidence-based practice. So there's been some support that that does address how effective it has been in having a great positive impact on clients and patients in different settings. This practice is used to identify, reduce, and prevent problematic use, abuse, or dependence on alcohol and illicit drugs. And it's a wonderful opportunity to start a conversation with individuals who either are starting to perhaps misuse substances, or maybe they're at a point where maybe they need a little bit more support. And so oftentimes, as many of you are already in the healthcare world, you have the opportunity to have contact with these individuals. And what SBIRT does is it opens up a conversation. So then it creates an awareness, so individuals have an opportunity to reflect on their own patterns of use to see if maybe there can be a change or not. In the past, it was more common to work with individuals who already had a dependence or a substance use disorder, moderate or severe, before intervening. What this model does is it allows us to be a little more proactive and reach individuals before it gets to the point where it becomes too problematic. And maybe just some warning signs are presented. As you can see here, not everybody has a problematic approach with alcohol or substance use. Though we do want to take an opportunity to touch base with individuals that we encounter. And we'll do that by using a screening tool, which we'll cover in just a moment. And part of this intervention is just, again, to ask some of those questions that sometimes people might feel a little uncomfortable asking in the beginning, or maybe answering, but through the communication skills that we'll cover using a motivational interviewing technique, hopefully that conversation is a little bit more comfortable and it allows clients and patients to do a little bit of self-reflection and maybe think about their health and maybe their life a little bit. So I mentioned before, it's an intervention approach, targets those with non-dependent substance use to provide effective strategies for intervention prior to the need for more extensive or specialized. What's really kind of unique about the SBIRT model is that it utilizes some counseling techniques that we might see in a more traditional counseling setting, but we see them being practiced in healthcare facilities. We may even see them in emergency rooms, in trauma centers. As you can see with the numbers there, there's, goodness, 7.6 million individuals a year who enter the ERs or the emergency departments every day for alcohol-related injuries and illnesses. And this can range from having a fall to maybe too much consumption to maybe some other chronic conditions related or exacerbated by the alcohol or drug use. So the initiative is to have SBIRT a common practice in trauma centers, and in some regions it's actually being mandated. So individuals and healthcare providers are being trained and required to use the screening tool in trauma centers because of how common alcohol and drug related issues are. The nice thing is that insurance companies are starting to recognize the benefits of this early intervention tool and is now in many regions reimbursable, which is nice. And I always say this is it's a window of opportunity. And so with you, when you're working directly with individuals and they come into the trauma center or healthcare center, oftentimes it's with some sort of ailment, it's with maybe some concern. And oftentimes people or individuals feel a little bit more vulnerable at that state. And so there is like a perfect opportunity to just say, gosh, Mr. Jones, this seems to be the second time there's been a fall related to a barbecue event where there was a little bit too much alcohol consumption. How about we have a conversation about that? And oftentimes that's that perfect opportunity for individuals to say, you know what, maybe this is an opportunity to cut down. Maybe I don't want to have any more injuries related to having a little bit too many on a Sunday afternoon. And that's when there's some major changes and improvements that can be done. So when we actually look at the SBIRT tool, it consists of three major components. And the first piece, the S in SBIRT, is the screening. And this is a screening tool that can be adopted by your healthcare center, or just something that, even if it's just some sort of questionnaire, but usually it's recommended to utilize a standardized tool like an audit or a craft or a DAST, which we'll cover. And in the screening tool, there's an opportunity to talk to individuals about their patterns. So we start asking the questions. Sometimes individuals feel like, oh gosh, isn't that a little bit too intrusive, or might people get a little defensive? But that's where the motivational interviewing and some of the kind and empathetic approach can really benefit you in hoping to engage the client or the patient. So they don't feel judged, they don't feel like they need to minimize their use, that we're coming in from a place of concern and really getting them to just reflect on their own patterns. The nice thing about screenings is that one doesn't have to be, say, a trained counselor to utilize a screening tool, or have just a vast background with any other type of therapeutic skills. Screening tools can be used just with about anybody who feels comfortable in working with patients directly. Some healthcare providers feel very comfortable just reading the questions verbatim. And some just feel comfortable using some of that information and, again, starting that conversation. So the screening tool is where we start to get information about patterns. Oftentimes with screening tools, which we'll cover, is a chance to rate and get a score based on the responses of the patient. And that score is a good indicator of what we can use in the second part of the SBIRT tool, which is the brief intervention, the BI in SBIRT. And this is where we can do a little bit of psychoeducation. We can have a quick conversation. We can allow patients to reflect and think, perhaps if they want it cut down. So this is a chance to maybe negotiate a plan of change. And for some individuals, it might be a chance to talk about treatment options if the use seems to be a little bit more severe or problematic. The brief intervention, in my opinion, is probably the most essential piece in the SBIRT model, because this is where the connection happens. This is where we can have that discussion where patients feel like they can just really think about if they want to make a change or not. And oftentimes, too, they may not want to make a change then and there. Sometimes there's just a chance for them to think about making a change, and maybe going home and remembering that conversation they may have had with you, and maybe made some modifications to their behavior. So we may not see the effects right before us, but the wonderful thing is that whatever we say can have a lasting impact. And the RT in the SBIRT model, so again, we have the screening, the BI for the brief intervention, and the referral to treatment is an opportunity to be able to provide a patient with resources. And because, as we know in working with different clientele, some people don't know what treatment is, or maybe they base their opinion or their experience on something they see on TV, or hear something or read something on the internet, but may not know what a counseling treatment center might look like, or that maybe just meeting with someone once a week might be effective. So having that chance to educate patients on what is treatment is also a great way to break through some of those challenges and a little bit of that pushback that patients might have. Sometimes there's fear. Sometimes there's a little bit of negative stigma related to accessing treatment options. And so part of that brief intervention and then that segue into a referral to treatment is a great way to just offer just information to our patients so that they know, they can walk away feeling confident that they know what those next steps can be. Ideally, if you have access to treatment facilities or providers or cards or even what we call do a warm handoff, where we can actually help with that transition to say, gosh, there happens to be somebody here at our facility that can meet with you. Let's walk over to their office. Even better. That's a beautiful thing about integrative treatment options. However, if your facility doesn't offer that on site, just having a list of referrals, which I believe Brandy provided to you under the materials, under the little section there, where there's a list of all kinds of providers that you can have on hand that you either make a copy for your patient or just review some of those with them. Because just taking those extra steps, again, can really help alleviate some of the stress and concern about the idea of treatment. So again, as an overview, the core components of SBIRT is doing a screening and really trying to make it a normal routine in a medical or other community settings. I know most of us who see our doctors or healthcare providers may actually fill out screenings. So maybe they include it in the intake packet, or doctors or nurse practitioners ask some of questions as part of the routine. And that's what we really want to see with this model. So incorporating a screening tool like a short one like a DAST or an audit, and just as the more that we ask it, the more normal and comfortable it's going to be for us to ask those types of questions. And then not just do a screening just for the heck of or the sake of doing a screening, but to also have the chance to review the screening results, do a brief intervention. And with the brief intervention too, if we happen to work with a patient who maybe doesn't have any problematic use, or maybe there isn't any alcohol or drug consumption, or maybe if so, it's very minimal, there's actually an opportunity to really commend them on good healthcare choices and really comment on that too, and using affirmations as a method of really acknowledging just their life choices. At the same time, we also want to use affirmations to those who you might need a little bit more support. That's part of the whole motivational interviewing approach, is to be strength-based and positive. Oftentimes in the past, we've seen models where if individuals say, gosh, I'm drinking 3 or 4 glasses of wine after work at night because I'm stressed out, there is a tendency to maybe be a little judgmental about that level of consumption, or maybe be concerned. With this model, with the brief intervention, we're not going to shame. We're not going to hopefully make anyone feel embarrassed, but instead just say, okay, so it sounds like for you there's some stress going on at work. Let's talk a little bit about that stress. And then when you drink 3 or 4, what's that like for you? And what are some maybe negative consequences that you're experiencing if you're having 3 or 4 at night? And that's when someone doesn't feel judged. They might think, well, gosh, I wake up with feeling a little headachy, or it's hard for me to get my workouts done. And they're starting to make their own arguments for change. And we do that by asking just a couple of open-ended questions. And some of you might be thinking, you know what, we're very busy. We may not have the time to have these conversations with individuals. But what's surprising is that we can accomplish a lot in a 5 to 7 minute conversation just by asking just a couple of open-ended questions to say, gosh, you know what? I guess I do realize that maybe I could cut back a little bit. And then just responding back with another open-ended question. We want to be careful not to give advice, because that's where we see some people maybe shut down, maybe not follow through, because it's not coming from them. That's part of the MI model. So if we approach it to say, gosh, you mentioned 3 or 4 glasses gives you a headache. What's one thing that you can do differently in the coming week that might prevent you from engaging or feeling this way? And having individuals come up with their own responses. And then we can follow through with, how ready are you to do this? And then have that conversation. So it becomes an encouraging one, and one hopefully where somebody walks away feeling that they can do it. So that's part of the brief intervention. And I mean, here the model says brief treatment. That's part of, again, there's sometimes you see a few different models, but for the most part it's screening, brief intervention. Treatment is like the negotiation, the discussion. And then if you do feel that there is a need to referral to treatment, you can follow through with that. So let's talk a little bit about the screening tools. So with SBIRT, there isn't a 1, 2, 3 just required screening tools. There are many out there. These are just a few that are optional for you and for your facility that have been standardized and have been pretty popular. With adults, we usually can use an audit or a DAST. With adolescents, we use something called the CRAFT, and we'll look at that. And we have something for our pregnant patients. It's called the 5 Ps. And with our pregnant patients, we probably do really want to work a little bit closer to try to see if we can have some sort of intervention, because we know, of course, of the negative effects of alcohol use and with pregnancy. But the key piece is, as much as we want to give advice or give the statistics, we really want to get the patients on board with this. So this is an example of the DAST. So when I mentioned screening tools, they're not very, very long in length. We really want, typically screening tools are brief, because it gives us a clue as to what direction we can take. So it's not a full assessment. It's usually a list of 10 questions, maybe a few more with the audit. And as you can see here, this is the DAST. So we ask questions of, are you unable to stop using drugs when you want to? Do you ever feel a little guilty about your drug use? Have you neglected your family because of your use of drugs? As you can see here, the DAST is related to more drug-related, drug-directed questions. And I'll give you this slide, and you can see on the side I have a link to the DAST as well as a scoring sheet. So I didn't include the scoring sheet on here because we don't have quite time to go over the scoring, but it gives you just an idea of what might be on the questionnaire. It's certainly okay to soften some of these questions. I have found that it's been sometimes, if they're a little bit too direct, I might say, gosh, has drug use ever negatively impacted your family or your responsibilities with your family? So once you become a little bit more familiar with some of these screening tools, you certainly can do a little bit of rewording. So based on your feel of the client or the patient. It's probably a little hard to read, but this is an example of the audit. So the audit directs more alcohol-related questions. How often do you have a drink containing alcohol? And this is scored based on a 0 through 4 scoring range. So 0 from never to 4 times a week. What's nice about most audit tools is that it gives us a guideline of what drinks are. And I'm coming to you right now from Las Vegas, and so chances are if I went into a place and ordered a glass of wine, it probably wouldn't be 5 ounces. It probably would be more generous than that. So this is also an opportunity to educate our patients as far as what is a standardized amount of drink. So they're on top. If we're not sure, we're reminded of a standardized drink is a 12 ounces of beer or 5 ounces of wine. 1.5 ounces of hard liquor. And if you're kind of curious as far as what does 5 ounces of wine look like, I would just say kind of just a rule of thumb is if you imagine a bottle of wine, if it was divided into about 6 glasses, that would average probably about 5 ounces of wine. So that would be one standardized drink. So again, there's an opportunity to remind patients how much is one drink, 2, 3 drinks when it comes to healthcare standards. This is the CRAFT assessment tool. So this is the tool that we use with our adolescents. Again, questions are a little bit different, a little bit more worded for our younger patients. So questions such as, have you ever ridden in a car driven by someone who was high or been using alcohol or drugs? Do you ever forget things you did while using alcohol or drugs? So again, 1, 2, 3, 6 questions, and then we get a point for each one of those. And there on the bottom, if you have an opportunity to click on the link, or even honestly, these are out there in the general public. So if you Googled CRAFT or CRAFT scoring, you would get those responses. And again, that just gives you that chance to say, okay, let's see how I can follow up based on the tool. What's nice about the screening tools, again, is it opens up a conversation. So we have the questions, but we don't want to let the patients hanging. It's also, too, a great way for us to have a standing, like a mutual starting place. So we start asking about friends and family or getting in the car based on the tool. We can then use our brief intervention to open up, again, that follow-up conversation. So you don't feel the pressure of just asking someone about their alcohol or drug use. You have something to start with, and then it just nicely moves into more of that interaction. The benefits of screening, like I mentioned, is there's just a great way. If you're working with an adolescent and they don't get into cars with friends who might be high or drink alcohol, wow, what a great opportunity to give a high five or just to really praise that adolescent for their wise decisions. If they say that they do, that's okay. You know what? Let's talk a little bit more about that and see what we can do to kind of help you with making other life decisions and creating awareness. So again, really trying to be strength-based and trying to use normal, not judgmental approaches with our patients so they feel comfortable with us. And that's, again, part of our brief interview. So when we start to become more familiar with SBIRT and the normal consumption of alcohol and drinks, the conversation is going to flow a little bit more comfortable for us. But part of it is being educated ourselves. So part of the SBIRT model has us look at what are the standardized or the number of recommended drinks one can use before we start to see perhaps a little bit of maybe problematic issues or the potential to have problematic issues. So the standardized tool that we use here in the United States, we might see this a little different in other areas, but here is that when we're working with women, we really would like to see women not drink more than 2 drinks per day and not more than 10 per week. And with our men, to see that they drink not more than 3 standardized drinks per day and not more than 15 a week. And to really try to have at least 2 alcohol-free days per week. And there's a science behind this. So these aren't just numbers just thrown out there. There's numbers that support that if one starts to exceed these standardized recommendations, that there's a higher tendency to have either health effects, negative health effects, or social negative effects, or just responsibility effects. So just maybe negative impact at work or with other responsibilities. Or as you can see, the more that one drinks, there's certainly a higher risk of injury. As you can see with women, once there's more than 4 drinks or 5 drinks for men, that there's a much higher chance of some sort of injury to occur. And with our pregnant patients, we really do want to promote no drinks throughout the pregnancy, if possible. So you've heard me mention motivational interviewing a few times, and so I'd like to spend a few minutes actually talking about this. And in the longer workshops, we actually spend some good quality time talking about the MI style, because it's a practice. It's a way of relating to individuals. It's a communication style that sometimes takes a little bit of practice if we're not typically using an MI approach. But what the heck is motivational interviewing? Well, it does have its history based in the alcohol and drug field. So we do give credit to Dr. Bill Miller and Dr. Stephen Rolnick for taking some components of Carl Rogers' client-centered approach, but putting a twist on it by using a client-centered, client strength-based approach, but also being a little directive with this. And also using motivational interviewing to help promote the engaging intrinsic motivation to make a change in his or her or their lives. So oftentimes we use MI when someone is ambivalent about something. They feel 2 ways. Do I want to go to the gym? Do I not want to go to the gym? Do I want to change my diet? Do I not want to change my diet? Do I want to cut back on my drinking? Do I just want to drink as I already am, the status quo? So sometimes when people feel a little stuck or they're kind of in between a decision, motivational interviewing comes in and gives us some tools to ask some questions and engage that client in a conversation to help them maybe lean one way towards the other, and hopefully leaning towards a positive change that's going to benefit them. I use motivational interviewing all the time. As Brandy mentioned, I am a mental health therapist and a substance abuse counselor and an instructor, and I use this with students. I use this approach with all my clients, and because I just find that it helps to keep the conversation productive, strength-based, and empowering. So then asking questions to help clients and our patients to discover their own answers, their own reasons for change. You see light bulbs go off all the time, and it's really quite incredible to see. And I do it in a non-confrontational, non-advice giving approach. And it seems to really be effective. Even if the clients or the patients are not ready to make a major change, sometimes it just inches them towards one or the other. So the next time something happens, maybe there's a higher inclination to make a change then. So sometimes we're just planting the seed when we're using motivational interviewing when we're working with patients. Some of the MI core principles that are strength-based include the following 4. And if you walk away not remembering anything related to MI, hopefully remember at least one or more of these principles, because this can really be helpful in that communication style. The first is expressing empathy. And again, this is, as many of you know, as healthcare providers, a little different from sympathy. So we're not really feeling sorry for the individuals, but we're really feeling with, like really trying to understand what they might be going through in their own shoes. So really, if somebody is drinking excessively, to really refrain from even thinking, oh my gosh, this person is irresponsible, or this person is a terrible parent, because oftentimes even what we think can come through with our communication style. So instead, listening to people's stories and really feeling, my gosh, this person's got a lot on their plate. They are handling so much. And unfortunately, right now at this time, alcohol or substance use is the only way they feel or that they know that they can do to cope with the stress. So when we approach it from that perspective, it's going to come through with our communication. It's going to come through our eyes. It's going to come through our tone, and it's going to help clients or patients feel very comfortable, more comfortable. Not every patient's going to feel comfortable. We're always going to be faced with some that might feel a little uncomfortable, and that's, as you can see, that we're going to get through number 3. Number 2 is developing discrepancy. And this is a little trickier because it takes a little bit of practice. And so this is where we start to hear somebody's story, and we hear these this back and forth like a teeter-totter. Gosh, I'd love to lose weight, and I'd love to just be able to play with my kids. You know, at the same time, gosh, you know what? Having that glass of wine or having just a joint at the end of the day just relaxes me, and so it's so hard for me to play with the kids when I get home. So we're hearing 2 sides of the story, and sometimes we can use motivational interviewing to present both sides. So on one hand, you mentioned that you like to get relaxed. On the other hand, it sounds like you really want to play with your kids at night. So let's talk a little bit about that. So presenting both sides, because then sometimes that's clicks for patients to say, yeah, you know what, I think I do want to play with my kids. Maybe I can do something else at night to help me relax. Excuse me. Rolling with resistance is a very important part of this technique, the SBIRT tool, excuse me, because we're going to be faced with patients. Take a sip of water here. Excuse me. Sorry about that, everybody. Let me take off. Actually, just getting over a cold. So, okay. Rolling with resistance is important because we're going to be faced with patients who maybe don't want to talk about it, who may minimize, may not be truthful, but that's okay. We want to just still be kind and empathetic, and not even if somebody comes in and we know they're quite intoxicated, or maybe they don't want to admit to anything, we're not there to force them to give us the right answer. We're there to just roll with it, and then maybe when they're ready, that'll be another time. So we don't want to force anybody to make a change if it's too premature, because sometimes if we push it, then we push away the client's maybe just their willingness to make a slight change. So we want to be careful with that. And again, we really want to support self-efficacy, which means we really want to believe that they can make a change, and really acknowledge when they say, gosh, I think I can actually cut back, maybe do a little bit of harm reduction and not drink 4 glasses of wine each night, but maybe break it down to 2 glasses. Wow, that's huge. That's making a difference. That can make a huge difference in their lives, and promoting that self-efficacy, believing they can do it, and more importantly than that, helping clients believe that they can do it. So part of what MI does is that it helps us and to accept where patients may need to make a change, and so remembering that people are coming in at different levels with different attitudes, and may not be ready to make a change or ready. And though we don't really have time to talk too much about the stages of change, if you ever want to learn a little bit more about motivational interviewing, this is a model that's incorporated, kind of weaved into the MI approach, and that's really looking at the individual where they are with making a change. Maybe they're pre-contemplative, where they don't feel like there's any problem at all. However, if they're maybe contemplative, where they're thinking, maybe I can make this one little change, or maybe I can see how I can benefit from not drinking 7 days a week, there's a chance that we can use some questions to expand on that a little bit. And then as you can see with the stages of change, when it comes to all of us making a change in our lives, that sometimes we start off thinking, well, maybe, and then preparing to make a change, making the change, maintaining it, sometimes having a slip here and there, but hopefully making it part of more of a permanent change in our lives. And so this is the Prochaska and DiClemente's model. You know, and again, remember, each person may be at a different place, and so honoring where they might be. So sometimes people have been trying to cut back for years and haven't been quite successful. Sometimes people just need a little bit more time, and so that's what part of that brief intervention is for. So I'm going to move it forward because I'm recognizing that we're getting shorter on time. So another approach with the MI conversation is using what we call our ORs. So there's always acronyms. So there's an OARS, and in brief, that's using open-ended questions, using affirmations when we can. So giving positive feedback with our affirmations. It's like a compliment, but something that's genuine and authentic. Reflecting back what they say, and then maybe using a little summary. So from what it sounds like today, we talked a little bit about some of your alcohol use. You mentioned that sometimes you feel a little headachy on the weekends, and it seems like that you are willing to cut back. And so you mentioned that your new plan is to maybe drink 4 days a week rather than 6 days a week. So how does that sound to you? How ready are you to make this change? So summarizing what you've talked about. So there's like, that helps to formulate a plan that a patient can walk away with. And we just want to be very mindful, because as we start to use terms related to the alcohol and drug, I'll say just topic or area, that we want to be mindful of using positive language, because again, this is a sensitive area for many people. So we really want to make sure that we don't use terms like addict, or many addicts do this, or people, maybe you just want to try to stay clean for a while. Even if somebody is in recovery and they might use those terms, we want to use terms that again are professional and don't have any sort of negative connotation. So instead of saying an addict, we might say a person with a substance use disorder. Or instead of saying a person has a dirty drug screen, that person has a positive drug screen. Because the more we practice it, the more that we are trying to decrease the negative stigma related to this area. So even behind closed doors, even when we're working with our colleagues, to really try to use the language that is not negative or condescending in any way to those individuals who might have some alcohol and drug patterns, if possible. Oops. And again, I apologize for going quickly. It's just this is a lot to cover in a short time. And another thing that we can use in motivational interviewing is something called the readiness ruler. So sometimes when we're working with an individual, we've got 5-10 minutes to work with them, and we want to just start wrapping things up a little bit. We can do something called a readiness or confidence ruler, where we might say, gosh, you mentioned that you're thinking about making this change on a scale of 0 to 10. 0 not being not at all, 10 being very confident. How confident are you about making this change, or cutting back on alcohol, or maybe abstaining from marijuana use during your pregnancy? And they might say, gosh, I'm at a 6. And we might feel inclined to say, why a 6 and not a 7? But believe it or not, we might have more success by saying, gosh, all right, 6. Why a 6 and not like a 4 or 5? Because then there's a chance for us to hear why they are as confident as they are. And then we can, from that, might see what might it take for you to get to a 6 to a 7. So basically affirming where they are and how ready they are can create some really positive discussion between the two of you. So how confident, how ready are you to make this change? Because sometimes just walking away, imagine like if someone said, all right, so we're about to wrap up. All right, on a scale of 1 to 10, how ready are you to go to the gym today? And I said, oh, I'm at a 7. And so I'm gonna walk away with that feeling, probably maybe a little more motivated than when I walked in. It's amazing how these little exercises can really excite and inspire motivation. And we talked about the oars. So again, in a 5 to 10 minute, just brief interview of motivational interviewing, as it ties to the brief intervention, what might it look like in action? Well, hopefully, through the brief intervention, we have our screening tool, we have the chance to do some psychoeducation, and we have the chance to be friendly, using our empathy. We can ask permission. Would it be okay if we talked a little bit about your results? We really want to avoid judgmental communication if possible. We want to roll with the resistance if individuals feel a little uncomfortable. We want to support efficacy. And if we remember, we can just engage our clientele with our open-ended questions or affirmations or reflections in our summaries. And there's some amazing tools out there. So if you're ever stuck to say, my gosh, how the heck am I going to remember all of this from a 45-minute webinar? There's some wonderful tools. In fact, these are some cards that the Lindsay Institute have. So if your facility would like just a packet of these, I call them like little cheat sheets or little postcards that have just these little reminders of what we can do when we're starting to practice SBIRT. So as you can see, just in this little card here, that we're reminded of what our oars are. There's another set of acronyms that ties into the spirit of MI, which we talked about. It's just a different acronym. We have a ruler there on the bottom. And then if we ever feel really stuck in how the heck do we start a brief intervention with someone once we get the results, it gives us a little guideline. So is it okay? We're asking permission if we talk about your results or your substance use. And we'll talk about the results of the screening tool. It says offer advice, and I keep saying offer advice. Offer advice, it's not really offering advice. It's really asking about their goals for their own personal goals of making a change in their lives, enhancing motivation, and then negotiating a plan. And so these cards can be available to you, or I actually found this I think I Googled it, and so even able to print something like this and then just have it available. I know I used cheat sheets for the longest time when I was learning this tool. The last part of the SBIRT tool is the treatment. So as we recall, we have the S for screening, the BI for brief intervention, and then the RT is a referral to treatment. And this is where we might want to become a little more knowledgeable ourselves as far as what are treatment options in our community. So we might learn what an outpatient facility might look like. So working with a provider who might offer counseling sessions one time a week or group sessions a couple times a week, and learning about it. So when patients ask us, because now they might feel comfortable with us, to say, what does that look like? We can give them a little bit of background of what outpatient might look like versus intensive outpatient, which is more about just going more often to the therapy sessions. Or for some, it might require some residential care, so staying there at the facility for a while. For some individuals, it might mean detox, and what might that look like? And maybe for individuals, there's medical assisted treatment. So those are for our patients who might have a physical dependence on opioids. So looking and talking to our patients about that as well. And letting them know what individual or group therapy might look like. Because again, many people might just have this kind of negative stigma or just negative just perspective on what treatment is. And there's again an opportunity to break through some of those challenges. Because when we're working with patients, we really want to see the whole SBIRT model through. So we do the screening, we do the conversation, and if there happens to be some indicators that let us know that that person could probably benefit from working with a provider or a counselor, that we don't want to necessarily just give a card of a therapist, but perhaps talk about insurance, what that might insurance options look like, what are the next steps, what phone numbers they can use, transportation issues, hoping that they walk away feeling confident that they know what steps to take. And again, this is just a copy of one of the writers. This is a snapshot of the materials. This is one, I believe, out of 7 pages, I think, on one handout, and there's another. So there's lots of wonderful facilities in your community. You can see that it's listed through the agency, how they're funded, what type of services that they offer. So early intervention or outpatient, or if they offer drug court. So it gives you a little guide on what's out there. So it's really beneficial and helpful to patients to just know, gosh, I know New Frontier offers this type of services. We live you live pretty close to community counseling center. That might be an option for you. They have Spanish speakers. So having this resource can be very helpful to our patients. So is SBIRT effective? It has been. There's just been, again, so much positive support. It's interesting because I was originally trained as an SBIRT, I'm going to probably just guess about 8 years ago. And I was trained in New Jersey. And I didn't live in New Jersey, but I went there for a training. And I was just blown away on how much this was utilized in integrative services. And just the number of attendees, the number of professionals from so many backgrounds very interested in this tool. And slowly we've seen this wave come across to the West Coast. And so this doesn't seem to be just kind of like the trend of the week or just something that might come in and out, but really something that they've seen make a big difference in the number of alcohol and drug related opportunities to reach individuals. And there's just, again, a lot of support that indicates that this is an amazing tool that your agency can use. So in brief, that's kind of an introduction, an orientation of what SBIRT is. I like to put this little Snoopy on because sometimes we think about it and then we think, gosh, what does it actually look like? Like if I'm expected to do this tomorrow. And I just wanted to spend a moment to say it does feel a little uncomfortable in the beginning to ask someone about some personal questions. For many of you with healthcare, though, backgrounds, I imagine it might be easier, say, than someone maybe who's working at a community center, who's a receptionist, or somebody who's not used to asking those type of personal questions. But many of you already with healthcare backgrounds, already asking about health-related questions. Hopefully, you can interweave that into your practice, and it'll feel more and more comfortable as you go on. The key piece is with the SBIRT tool, it's about creating that awareness, education. I can't tell you how many individuals don't know what a standardized drink is or what the normal recommendations are. Sometimes just informing and educating someone about what those standards are is enough. Some people, because they just heard from their healthcare provider, I shouldn't be drinking more than 2 glasses of wine per day. So, gosh, my healthcare provider mentioned that to me. I think I might stick with that. Sometimes that's all we need to do is create awareness and education. And for some, maybe having a more open conversation, because that can create just some amazing, important changes. Oops. Because as we can see, just in the past year, just knowing kind of like what we can throw out there, how it can impact school, drinking, again, there's so many amazing tools out there that we can use to educate ourselves and educate our patients. And so there's some beautiful graphics out there you can use. There's also some amazing, and I keep using amazing, I don't know, I guess I'm getting excited here, some wonderful YouTube videos that I included links for. I use this when I do the longer workshops. This is a really good 10-minute video I encourage you to watch because it just talks about talking about alcohol and health in a way that's more, let's talk about this and let's throw the judgment out of the window and let's talk about it in a conversational manner. And I also provided links to seeing SBIRT in action. So these are 3 vignettes where you see a provider work with the patient, and you see the whole SBIRT, just the process in action, because I know for me, I like to see examples. So I think, goodness, it's 12:57 on my end. Didn't leave a whole lot of time for a Q&A, but I certainly have time for a question or two as we start to wrap up. I really want to thank you all for hanging in there with a lot of information. If you have any additional question, I provided some contact information for me, for Brandy, who is our host today. So thank you, Brandy. And then for also Stephanie Boreen, who's part of the Lindsay Institute. So if your agency would like more intensive training, or you think you would benefit from an in-person just workshop, she would definitely be the person to contact. So, and I thank you all for your attention and for your time this afternoon.
Does anyone have any questions for Roberta at all? If you do, just make sure you unmute your line if you want to do it over the phone. Well, thank you, Roberta, and thank you to everyone for attending today's webinar on SBIRT. If you have any further questions, like she mentioned, our contact information is there. Feel free to reach out to us. Once you leave today's webinar, you'll receive a survey on the presentation, and we'd appreciate it if you can complete that and then provide your feedback. You have to finish this in order to receive your CEU credit. On behalf of Nevada Primary Care Association, thank you for joining us today, and have a great rest of your day.
Great, thank you. Have a great rest of your day.